Jumped in.
No, you're
Unless that's
yeah, it sounds like you want to do it. Not all of them, but it's relationships.
all right. So this month's going to be a little different. I don't think we sent out an article, but we did a meta-analysis last month. So this is sort of building on that. The overall topic is looking at scientific misconduct, and then we're looking at what happens when you have such flagrant scientific misconduct. Yes, it's also a how-to. Yeah, no, you can use it, but we're gonna take it from a how-to approach. So, what are all the ways that you can conduct scientific misconduct, so that then you can be a little more in tune to how things can go wrong and what happens. So, using what we learned about a meta-analysis last month, we can look at what happens if a third of the papers in your meta-analysis were fabricated. So that's what this month is about. So there's nothing really to read ahead of time. Here's our learning objectives: to understand the types of scientific misconduct, learn about what happens when this happens on a systemic scale, and it happens every day. There's a few key historical events that are worth knowing about. I even heard you guys are talking a little bit about IRBs, like how did we get here? There's like endless paperwork. It's an enormous pain. When you hear about the stories of why IRBs even came about, it kind of puts it in perspective why they're pretty careful and protective of research subjects because of relatively recent events. And then we'll look at a meta-analysis that to see what happens when you have systemic unethical research. So before I go to the next one, we're going to do the how-to. So how are you going to fabricate, or like what are ways that you can make research go wrong? Unethical.
Making up data.
Making up data. That's a good one. So don't do research at all. Just start with the answers, fill it in, win grants, do whatever you want, right? Perfect.
Yeah. Good.
What's other ways? That's pretty flagrant and it's totally done and awesome if you want to be terrible. But what are other ways?
Using subjects that don't necessarily give their consent, or you're taking advantage of them in some way or another.
That's a good one. What's another way you can get a unethical or
being subjective with how you analyze the data and picking and choosing.
Nice. That's good.
Especially if you're being financially supported by someone.
So with all the money. So before, so we'll build on those, but who can commit the fraud or who can be involved in that? Like there's several levels, and I think the funding gets at it, right? So think about what areas can you do unethical research? Like who can be involved?
Pharmaceutical companies.
Right, so people paying for the studies, that's one way to do it. How else?
People doing the studies.
Researchers. There's one more. Maybe there's more. There's probably a
There's
ton more.
multiple levels of researcher. And they all have different reasons.
Statisticians, yep. Then what about who you send the paper to?
The reviewers.
Reviewers? Who else can be in on this fraud game?
Journals.
Journals, yeah. How do the journals benefit?
You read more of them.
Yeah, so they're business,
You put
right?
out more journals
money.
with good, seemingly good quality content. People will want to read them.
If it's like new and
subscribe to them.
exciting.
How are editors judged? By the society that puts them in place? So, for instance, the editor-in-chief of anesthesiology is put in place by the ASA. Okay? And how does he or she keep their job? The impact factor of the journal. So it gets to your point exactly, which is you want things people are going to cite and read. So the more they cite it, the more they read it, the more sexy the article.
More citations.
More citations.
Yeah, so
And so it could be,
become the landscape.
they could be knowingly complicit or just some.
there's a few other more nuanced
Rarely.
ones. So
Rarely.
authorship
No.
attribution,
Right.
right? So there's this idea of gift authorship. So you just put someone on there to have their name. Yeah, it's a gift. But there's certain criteria for authorship. The other one is a more subtle one. So citation bias or a citation amnesia. you say you're the first in the world, you ignore the one that was published like 5 years ago in a tiny journal, no one saw it, and, no one figures it out, and you say we win, right? So there's that. There's even, there was a Nobel Prize winner who completely forgot that he had done a study and redid it 18 years ago. So there's this republication. So you can take your same data and shop it around. So that's another way, right? So it's hard to do research. You can get IRB approvals, right? You can publish the same study, put a little spin on it, or republish things. If you add just a little bit to stuff you've published before, instead of citing it, you've got a whole new study. So there's other nuanced ways.
But is that actually? I mean, I know that's like
Yeah, is
not
that
fair, but like
misconduct?
it's just representing your data. So I don't really necessarily think it's.
As long as you're upfront about it.
Yeah.
Here's a question: can you plagiarize yourself?
Yeah, I think yes, because you're.
Yes, you
But I
can.
would say no.
Well, if you copy yourself, it's plagiarism, which makes it a better question. And then this gets into like copyright, and yes, like a lot of people will either reuse like an intro or something. And that's a probably more mild form of sort of scientific misconduct. But obviously, there's a gradation on this. So there's a review article that went through some of them. I think we got most of them. So we got who. So we got researchers, research reviewers, funders, sponsors of any kind, anyone with a vested interest in it, maybe even a patient advocacy group, right? If they just want to see something get to a clinical trial, you've got a kid who has this rare disease, maybe you want to push on that, or have studies get something to try and get a therapy. There's other people interested. But so we talked about fabrication. So falsification is if you just change the data a little bit, maybe throw out a few points you don't like, that sort of thing. Also, photo manipulation has been a major issue. So you can take an image, digitally modify it, get a different result. There's one torturing the data. Keep running a ton of statistical tests until it confesses to something, and then latch onto that, and then hit the thing. Plagiarism we talked about. So omission. So if there's this whole body of work that doesn't fit your hypothesis, and then you just decide not to cite it, even just not including something that's been pretty well established can be a type of misconduct. Here's one: the journal self-citation. So reviewers may come back, or an editor may say, hey, you missed these 10 papers that were published in our journal, and they'll ask you to put that in. That's misconduct because now they're boosting their own impact factor. Because impact factor is how many citations do you have per article that you publish in that year. So just to give you an idea of the scale, so the top one is New England Journal. For every article published, it has 60 citations per year. So that's 60 impact factor. And then for reference, like anesthesiology is like 5-ish in that range. So if they can boost that up, it looks better. And then that's how they sell more journals. People read it. And let's see. So data manipulation, you can change things. Suppression. So this was a big problem before you had to register your clinical trials. I think we've talked about that a little bit. If you're a drug company and you have tons of money, you'll do 6 clinical trials. 2 look great and they make your drug look better than the other guy. The rest are null. You just bury the other 4. Sure, it was like $12 million to do it or whatever they spent, but it's more important to selectively choose those files. So now you can't even publish a clinical trial unless you say ahead of time. It's almost like in pool where you have to call your shots now. You're like, all right, the 8 ball's going in that pocket. Mm-hmm. Same thing with a clinical trial where you have to say, okay, we're going to do this. So you can't just bury those results, which is another form of misconduct. And then the big one, and this gets back to IRBs, is unethical human or animal experimentation. So do you know why we have IRBs? Have you heard of, there's 2 sort of big, egregious cases in history that sort of led to IRBs and our current standards. You guys know about them at all?
It's like the
Syphilis.
syphilis, yeah.
Tuskegee.
So what happened? What was this about and why was it a problem?
African American men and like with syphilis and not treat them to
They
just
told them
see
they were
what they told them they were or something, and then they just like see what happened. Something.
Yes, it's a little more nuanced. So that is what happened though. They were withholding treatment from people. without their consent, so they had no idea. So this was over 70 years. I think the funding started in like the 1900s. And they saw that like 35% of the reproductive age people had syphilis. This is a major problem. And it was untreatable. I think they were using mercury and something else and like were killing some people. The treatment, this is pre-penicillin. So they start this study to try and see what's going on and follow it up. But in the interim, penicillin gets discovered. Yeah, so it's like they've been doing this study for 20, 30 years. They discover penicillin. They decide in the non-treated group that they wouldn't tell them penicillin was invented or like available, and to just watch what happened until death. And the way they didn't even tell them they were in a research study. So they would offer people like free medical care and like food or something. So what are the issues? Why is this a problem? Like they had syphilis anyways. They didn't have access to medical care. Why not just watch them and learn something from it?
Because once you have a treatment for it, you can't not.
It's just terrible.
We've got any reason.
I don't know. We've got ECMO. Do we put everyone on ECMO? Like.
Seems like it.
Yes.
There's a cure for
I feel like any reasonable person that you told, hey, I have this simple cure for this disease that you have, I want it, they would say yes.
Right.
Robbing them from that opportunity.
Weigh the risks.
They don't have a choice, right? Like,
Right, you
They
still have to
didn't
give them a
choice.
choice.
They didn't have to go.
But once you knew there was a cure, you didn't give them a choice on what to do.
Yeah, that's true.
So
What are the other problems? So there's withholding care potentially, or just not telling them. So this gets to consent.
Like informed consent.
Right.
I didn't know they were being studied.
Yeah.
Yeah.
But let's
Can
say
you boil
they
it down to
live-
ethics?
What?
Can you just boil it all down to ethics? Like,
Yeah, we have ethics for sure.
yeah.
So what are ethics?
I mean-
we're just trying to learn about syphilis. What's the problem here? They were going to die anyways if they didn't have.
Yeah, but if you have a known treatment and you're purposefully withholding that, that is unethical. So, I mean, I feel like that's unethical. Not informed consent is unethical. I mean, there's just branches of not being ethical.
It's just all wrong. Right?
It's all
It's a
wrong.
lot of
Yeah. Okay, so yeah, it was pretty horrendous. So they didn't know they were being studied. They didn't say, okay, we can be studied, or yeah. So consent, so autonomy is definitely being violated there because they weren't informed of all the available options. So if you come back to your IRB form, like have any of you guys done them? What has to go in there?
yeah.
So like, what are sort of the cornerstones?
Like the pros and cons.
Yeah,
like
risk and
benefits,
Your hypothesis.
other options, how they could withdraw if they want to, if they're being compensated at all for it.
What are the exclusion criteria?
What like the current, if you're looking at like a treatment, what the current treatment is versus like what you're studying.
It's like the steps you're gonna take to protect the subject.
Right.
Right, yeah, how you're
So
gonna keep
think
it
about it,
anonymous.
there's coercion, these are poor black men, I think they studied, and they were coercing them with like food or something else, right?
Right.
So there's this like power differential, there's a knowledge disequilibrium, right? So they don't know either what syphilis is necessarily or that there's a treatment. And then they don't have, I think a big part of the IRB is like, what are my other choices if I choose not to participate? And to just know how they're going to be using that information. So that's sort of set the guidelines. So there's another, the next example too was the Nazi human experimentation. So this is a whole other level. So there was no scientific purpose or useful information out of that. So this was Joseph Mengele, I think, or however you say his name. Do you guys know about what was going on with this? Probably the most infamous of those were the twin studies. He thought there was something different about twins. So he did like not even like pseudoscience, like just comparing things in like 2,000 twin pairs. Like he would target them, and it was just horrendous. So what happened was this. So we've talked about what came out of that, right? So in 1947, they had the Nuremberg Code that sort of guided this. What is research, first of all? How do you know when you're doing a research study and you need an IRB?
If you need the IRB, because you're using humans, right? Like,
Some of that, right? So, but you can do quality improvement projects. It's not research.
You have access to their protected information you need. IRB.
Not necessarily. There's de-identified. So what are some of the risks? So this with those two examples. So consent seems to be a big issue. You need to say, okay, I'm up for being in research, and then one of the main ethics principles we've been talking about is autonomy, right? You get to decide what you do with your life and sort of what, right? So in order to participate in research, you have to agree to all the different stipulations and sort of what that's included. So what else? So there needs to be standards of like what you need to tell people, how to protect them, and that's sort of where all the regulation came out. So if it's human subjects research, it has to be identifiable. So you have to be able to link it back to a person. Otherwise, that's why if you're doing it with just data, that's sort of, you can't link back to individuals, then it doesn't have to do, isn't related to that person and their autonomy. But have you heard about the Henrietta Lacks story? What happened with that?
she had cancer. They did a biopsy. They part of it went to the lab to look at her cancer, and then part went to some study that she didn't consent to. And they replicated her gene line, and it's still alive today, and they sell it and they use it to study. And her family found out about it and were not pleased.
Yeah. So in the whole industry, they're HeLa cells, and they're used in every laboratory in the world. And the amount of them is 100 times her body weight, when she was actually alive, and they didn't tell her they were going to take her cells to use them for or profit off of them in any way. So now there's a clause in the IRB to talk about that, whether they're allowed to commercialize anything with it. Okay, so what about more recent examples? So this is not just Holocaust level stuff, right? There's some other examples of how people in our own field have fabricated a lot of data. Anyone heard of this one? So if you were going to fabricate studies for fun and profit, where would you do? Usually it's a drug company, right? You guys brought up funding. You go where the money is. So that's part of what this story is about. So he was an anesthesiologist affiliated with Tufts and Bay State Medical Center. So he had about 21 clinical trials looking at, I think it was COX-2 inhibitors in pain. So a lot of this was involved in sort of the multimodal analgesia field, sort of thing. Do you remember
sort
this
of
one?
established. He was the most quoted guy. It reminds me. I always think of it when anybody here watch Real Time Bill Maher. So the one where he goes, "I don't know it for a fact. I just know it's true." That's what this kind of research was.
Yeah. So he wasn't even doing the trials.
He wasn't. Yeah.
This goes back to full out. It's not even falsification where you're like, oh, if we just pushed a few of these and said they were in the other group. No, this is full out running out of going through the baby name book and running out. He reused names a ton, and birth dates were the same. Not even creatively. Yeah. But this is a problem. Okay, so fine. You make up 20 papers. You make a career out of it. That's one person, right? Well, no. For the same reason that you try and get into research and make a good impact on the world, there's a ripple effect from that. So this was a paper in anesthesiology looking at systematic reviews like we talked about last month. What happens if you've got Ruben in there and you're trying to ask a question about involving his studies? So if a third of the data is made up and it looks pretty good, it can shift a whole field down something that either doesn't work or is worse, even dangerous. So that's what this goes through. So they looked at 25 systematic reviews had used his papers at some point. They weren't retracted. And 1 in 6 out of these would have had the opposite conclusion if they didn't include his paper. That's on the quantitative stuff. On the qualitative, they usually read all the papers and make some sort of recommendation based on that. And they said like half of those probably would have either tempered their recommendation or changed it altogether. Because they went and talked to these people and redid the analysis. So it's a huge problem. Okay, so pretty good. He had 24 retracted. This guy, though, he's the best in anesthesiology for fabricating. His retraction watch count just went up to 94. I think last week I got that email. And there's a site that sort of keeps track of it. So his claim to fame was looking at starches. Do you guys use head of starch today? No? No? All right. We had a cut in residency. There were a couple bags in the back that I saw. I don't know when they were from, but no, I've never used it.
Dust it off.
So 95 papers. So this was the paper we were going to send out, but since we just did a meta-analysis, we'll go through it together now. So looking at what happens with that. So this is in JAMA looking at head of starch with and without this guy's papers. So they went through and this is your diagram if you remember from last month. They adhered to the PRISMA guidelines, so making sure that they tried to identify all the papers that were involved. So they start with close to 4,000, they screen them, get the duplicates out. So you have 42 papers that made it into the diagram. So this is a little hard to read, but on the right is showing that I believe usually the comparator is saline or some other crystalloid, and then it's head of starch on the left. So each of these is a study. Remember, the boxes tell you how many, and then the line is how much the results vary. So if you take Bolt's papers out, they all slightly favor, it's statistically significant. They're looking at 10,000 patients total, 5,000 each group, and it's significantly in favor of saline. Then if you look at Bolt's here, you see that he was pulling it to favor starch. Right, so then when you put those together, so you get an opposite result. It tempers these negative results associated with head of starch. And now if you just look at dialysis, then it's a really strong signal that this stuff is dangerous. You should not be using it. So head of starch was probably everywhere. Do you remember it being in the ORs a bunch? And do you have perspective on that? Like
The what?
When it sort of showed up and then left, or what?
Oh, I can't tell you when it showed up, but it was around that time.
Yeah.
And we had, check to see if we have any in here today, but we had some people who came from Europe and they were like, why aren't we using more?
Really?
Yeah, and then, we said, well, the studies here have shown that it doesn't work. And he says, yeah, but you're using the wrong molecular weight head of starch. And it took a number of years. It was a long tail on it. It peaked, and then it just sort of gradually, people realized that there was more and more evidence that it wasn't good.
Yeah, there's quite a few kidneys caught in the crossfire here, unfortunately. So, yeah, it's pretty appalling. So again, so that's not new, right? But this is still happening all the time. This was 2017. There was a whole very productive lab. A guy had his whole career in this. They were falsifying or fabricating, a little combo of both, that these heart stem cells were going to repair hearts. And then it came out that they had submitted all these grants that were based on falsified data, so they had to give the grants back. So a little less bad than I suppose clinically harming people, since it never made it that far. But it's a lot of money. It's still a big problem. And then even just this past few months, there was this fraud with had to give back $110 million. And the whistleblower, the person who found out that the lab tech was fabricating, falsifying data, I think there's a clause in there that as a whistleblower, if you find someone's defrauding the government, you get a cut. And I think they got $30 million. So they're trying to make it profitable, being what would that even be? What's the opposite of scientific misconduct? I guess you're like the research police or something. I don't know. It's very profitable, apparently, if you know anyone fabricating data, who's also rich. But it's starting to have major implications for institutions and for reputations. But there's another piece that's maybe not obvious. So, of course, falsification, fabrication's bad. I read a number of editorials and thoughts on this around something else. And that's the culture. And I think it comes back to the impact factor. So why are people even doing this? Everyone knows it's wrong.
Keep their jobs, that they say, like, publish or perish, right?
Yeah. It's incredibly competitive. And careers are made based on high impact. Well, those are pretty rare and pretty hard to find, even with doing all the right things, right? So there's a lot of talk about the culture of impact over everything. So if your boss or PI comes and tells you, I know this is true, go show me that it is, or you come back with negative results and like you did it wrong. Right. So there's the other side of that, but there's major implications both for health and research in general and credibility. Also, too, keep in mind it's not all drug company money. A lot of this is taxpayer money, right? So if they're defrauding 150 million based on falsified data, it's really not a good use of a pretty limited public resource that everyone's paying into. Right, so it's pretty important beyond just protecting human subject protection, which is really critical as well. But do you guys have any other thoughts about that, or how would you detect this? How would you even know? What are some clues that something might be fabricated or falsified? Or...
All positive results.
Yeah.
That was amazing, groundbreaking results coming out of this lab.
Every time, right?
Yeah, one of the things I thought you were going to maybe include, I mean, we had sent out a couple of years ago, there were, I can't remember the guy's name, he's Papadopoulos or something like that at Stanford, who is one of the main research guys who's looking at reproducibility. And this was a big story in the popular press, and especially The Economist, which follows business, but the reason being that only about 20-25% of the biomedical literature has reproducible results. And there's lots of reasons for it.
Yeah.
That N's are small, that's one, because you can only afford to do so many, but there's, it indicates there may be, bias or out and out fraud.
Well, and there's a mandate too, just for animals. So this comes back to animal ethics. Use as few animals as possible to answer a question. But then a lot of times the accepted N is 8 in each group. From our clinical stuff we've been talking about, we're talking about thousands, right? So you're sort of stuck in between those two things. To put that another way, if only 25% are reproducible, and you're spending $33 billion a year on research. So is that, what's 33 times 0.75? Is that how much is sort of wasted on false research? I don't know. It's not an exact
It's a big
one.
problem in pharmaceutical research. There are labs that are set up to do nothing but reproduce results. They're commercial labs. And pharma wants to know before they buy a startup, because that's what pharma does now. They don't have their own labs anymore. So they have some, but they used to have big discovery labs, and they maintained these big groups of scientists, and that's too expensive. So they let venture capital start on, idea pops up out of the lab, they start a small company, they start developing the drug, they look promising, and pharma swoops in and buys it for millions and millions. But now they're like, before we lay out any money, we're going to ask this lab to reproduce this.
So there's a culture shift, and I think they're trying to put a financial penalty on this as well. It's not just a reputation hit, because that seems to get people's attention. So $110 million is notable for just about anyone. So I think you'll start to see a culture shift. But if results are too good to be true, they're not reproducible, it's good to be skeptical, especially if it's only been seen in one trial. So we've looked at a lot of different study types and sort of the hierarchy of evidence. And you really need a number of clinical trials, meta-analyses, and even then, especially with the drug, you won't know until it's launched on a population level whether it's reproducible in sort of real-world scenarios. So the burden of proof is really high. A good example of something that's sort of passed all those tests, look at statins. I mean, they've talked about putting them in the water, and they've studied them for absolutely everything. And it's pretty hard to find a floor on their benefit for people with like hypercholesterolemia. So that's something that was reproducible and worked, but it's also sort of the most successful drug in history, I think, financially too, with that. So incredibly reproducible all the way to sort of newer things that may not be as robust.
Were any of the journals held culpable at all that accepted some of these fraudulent papers? Because, I mean, that also seems like that's a step where they have some responsibility to verify that, it's legitimate.
Yeah.
It's kind of too little too late. I mean, they will retract papers at some point if someone raises an issue of concern, but it's often years after.
Now, some of the journals have taken steps. One of the early adopters was actually anesthesia and analgesia, and it rapidly spread to anesthesiology, and I think all journals do this now. So do high school teachers. Anything that's submitted is checked for duplication. There was a lot of duplication going on. And especially, I hate to say it, but in lower tier journals like ANA, because people, as you said, they were looking for creative additional places to publish where it might not get noticed. And so they're now checking for word plagiarism. And it was funny because the editor said he caught himself. So he was a co-author on a paper, and he had done the pharmacokinetic analysis, and he had sent in, well, this is how I did it, and he pulled it from a standard text. And so he caught himself. But most of the time, if it's caught ahead of time and it's something like that, you can just say, hey, what's going on here, and you can fix it. The other place that's really gotten sophisticated, and we had a case here at the university where people are now using image analysis. And there are little cottage industries of people going to journals and submitting all of their figures, especially even histology figures, to image analysis, and they can detect. So that's things journals can do, but the review process, the reviewers are basically doing this out of the goodness of their heart. They're peer reviewed. And, they're not going to come marching into a lab and start auditing the data.
Yeah, it's sort of volunteer labor.
It's a real difficult.
Are academic institutions going to change that requirement to publish, to keep if you don't publish enough, you're going to be fired kind of mentality? Because that's fueling the fire. That's the whole reason people are doing that.
Yep. And do you know the backstory about the autism and vaccine connection? So, do you know what paper it came out of? It was
the Lancet.
Lancet, a tiny little paper though. They paid to have it published. It was less than 30 people, I think, in this study. And they just counted like who had got there. There was no statistical analysis, and they just said in like 16 people, some of them had autism and had vaccines.
Wasn't it self-reported also, like the parents said, oh,
Yes.
it looks like my kid has autism?
Yeah, around the time. And the reason he had started doing this is not because he hated vaccines. He wanted to sell like a different, he wanted to split up the doses or do a combined dose or something. So he's trying to say the current ones are like bad. Like either however they were doing it, either bundled or not bundled, he was going to sell a different version. He was paid by the vaccine company to do it. So that seemingly small, opportunistic, barely science paper had this massive cultural impact. And now there's measles outbreaks. Have you heard about those? Right, so it has real public health implications. So just make sure to keep a healthy skepticism about you and use the tools that we're going through with this to sort of try and look for that rigor in studies, right? And the healthy skepticism, I suppose.
And don't be shocked when you see it, because it's going to happen again. Yeah. We had one in here that was in the School of Pharmacy where a grad student fabricated dry lab 20 papers. First of all, how many PhD candidates can produce 20 papers?
Barely do one.
And yeah, you know, the PI was like chastised for. I mean, really, you weren't suspicious when this person had produced 20 publications for you in 4 years? So these things will happen will be close to home.
Nice.
Any
Okay.
other questions?
Yeah, final thoughts on that, or sort of a different format without the journal today. But I think it's critically important because you can't really talk about research without talking about where it can go wrong, what the historical perspective on some of this
Notice
is.
we did this at the end, at the beginning, because we want you to take Journal Club seriously.
Well, thanks for participating.
Full house.
Appreciate it. Hopefully, you got something you can use out of this with sort of evaluating research and thinking about it in broader terms. It's not just, you should be able to get something out of just about any of it by coming back to those basic principles of what did they do, with who, sort of what are the considerations, and how does this fit into the context of sort of what's known already. Thanks.
You guys have a COL lecture next, right?
Formalized our project. I went to one thing case and that's that from St. Windows. I was going to grab the deck.
Oh yeah, yesterday, MRI.
Yeah, I told them our whole story.
They're like, Annie can't go in there. Aaron, go fry yourself.
Full day.
I just sat there with Michael. He was telling me that he had it and it wasn't an attending or
Yeah.
a co-resident who like came up with like a long list of grade. Like, I was sitting in there like, how is there not a switch in the other room that just turns on and off?
Yeah, you just basically have to face out a.
It looks exactly like any other
Syringes?
I don't feel bad. You need cold.
Yeah, you need two syringes.
Oh,
You need
yeah.
two syringes.
Yeah, it's really
They're
good.
buying, there's some like, there are going to
It's hard to
vets. And these pictures.
I'm on the other side and she's like unimpressed with our ability to turn the vent on. And she's like, great,
Kind of.
people. I'm like, no, I didn't even get a breath yet.
So I would stop and at least give him a breath, and then she'd be like, hold it a bunch, turn it back on, turn it back off.
Yeah, it was pretty terrible. It was amazing. Chris just kept being like, so great. This morning, Kate is so great. He's like, I stand on the cardiac arrest. I kind of like stopped listening.
Doing an open thoracotomy. Okay.
Doing some real stuff. He's so funny. Cracks me up. Jump on it.
Thanks.
Yeah, I wasn't sure if it was.
IR angio and general OR and VA, which is really, I started. Oh, you didn't. Oh my god.
There's a flushing in my face and like watery eye. And it's kind of the worst.
Yeah. I walked up to yeah.
Sounds like the first one.
At least look forward to it. Like the
I left.
yeah.
So she was super small. And I wanted to be more super like his third year.
You all on the MRI. You in there.
I'm like
A half mile away. I have to talk to you. What is that going to do? What stupid is that going to do? Oh, this? Yeah.
no, lady, I don't know what you're talking about.
Like going up there, getting radiated. Yeah. Every day. Like, hey guys, let's go back to the
Complex cases for a week and then vacation coverage for a
Joe's
week.
not here to bitch you about it. Like, yeah. Like, okay, well, I'm here now because it was inpatient. You could sit outside. Right. And they were like,
Oh, for sure. Yeah, I guess that's what I was saying. You realize, you realize, you need all these things. There's like a million ways to do it. And like,
It's much fun to swear like mushing your bed like and you're like, do you try to go like check some information? You're like, stop!
you know
I
what?
keep radiating my child.
Their lives really suck. So, I mean, yeah, but their lives really suck. Right before Christmas, I was like, okay, we're almost done this year, but I was like,
Because she's like, I'm not going to be responsible for your alien.
did you tell Chanel? Thanks for that. Yeah, they have like
Yeah,
Chanel was like, I thought he was in.
Because it's the same people.
Anyways.
yeah, that's true. That's totally true. You're not doing all those lap colis at like.
That is
What is Kenji on? What is Kenji? What rotation is Kenji on? Kenji, what rotation are you on?
I'm at DJ.
Yeah. Why are you here?
I want to come lecture.
Did you have your meeting with Alila or something?
Yeah, that's right. And I wanted just edification.
Yeah, totally.
About 10 minutes for that meeting, I got really nervous.
Oh, really?
Yeah, me too. I was like, wait.
Evaluation.
Yeah.
If you want.
I was like,
Oh, no.
also I was like, oh my god.
Yeah, it's like,
It worked out okay. I'll go. Yeah.
I'm gonna come to DG at 10 on Friday for orientation.
oh, that's funny. You haven't been over there. Shoot, I'm gone.
You're gone.
Yeah, let me see. I mean, it's a funny crew over there. It's me. No, it's me.
Or no, not Lauren.
Justice, Adrian, Marcus, Dan Sert, and Sarah Morihara.
Okay.
That's a very funny crew.
Sorry, so you, Justice, Marcus, and who's the other squad?
Adrian.
Adrian. Okay. Yeah, shoot, Justice.
Dude, we just Adrian lost his phone charger and was texting us all like the whole day for it.
The entire day.
Yeah, I know. And then I like looked all over for it, and then I see Justice walking out of the workroom like with his phone charger. Like, where did you find it? I was like, I didn't know who it was.
And he didn't text him the whole day?
I
Of
guess
course not.
Yeah.
Of course not.
But so we put it in his
No, I
locker.
think Justice got it.
Did he?
I was like, Justice, you need to deal with this because I'm like actually doing cases.
All right, guys.
We stuffed it in a bunch of balloons in his locker.
That's remain for the lecture. I'll try to get this done quickly. So it's an exciting topic. Or hazards.
Yeah.
I worked with like half you guys, I think, and the other half I'll see at some point. Right. So oral hazards. So fire, electrical, lasers, fun stuff. Fires. So this is like our only talk on these hazards. So we'll kind of go through them, and a lot of them seem kind of obvious, but there are specific things that you want to know, especially for your boards and things like that, and obviously for patient safety as well. About 550, 650 fires per year. That is way too many, right? So have you guys ever seen a fire in the operating room or have something spark? And so a lot of times it's just something sparking, but we're working with things that, there's sources of fire that are clear. So, and some of them can be fatal, right? And a lot of them have to do with airways. So that's when you really, really want to be careful. So we joke about it. We talk about, I don't know if you've been in timeouts where they're like, oh, what's the fire risk assessment? And everyone's like, haha, we don't know. And they move on, right? But it's actually important, and no one really knows what the fire is. And we'll talk about what it is because it's actually a real thing. So fires in the operating room, it involves everyone, right? So the way I think about it, there are three different groups of people, right? So you have the fuel, which is the scrub nurse that's giving you the lap pads and things like that can become fuel for the fire, right? Oxygen source is usually us, right? We provide the oxygen, and then the ignition is the surgeon. So all three groups are required to kind of know what's going on because you can be contributing to a situation because you don't know what the other two groups are doing, right? So fuel source, that can be a lot of different things. Most of the time in the operating room, those are the drapes that we use, patients' clothing, things like that, hair, the egg crates. And then, so the flammable prepping agent, that's why ChloraPrep, if you look at it, right? It says 2% chlorhexidine and 70% alcohol, right? So it's basically, it's extremely flammable. And that's why, I don't know if you guys noticed, they say, okay, we prep, we'll wait 3 minutes. It's not because that's the magical number where, the antibiotics start working. It's the time it takes for the alcohol to dry up. And it's also required that because of that, a lot of times, I don't know if you noticed, in certain cases, if it's going to be pooled, they leave kind of laps while they're prepping, and they take it away, right? So it's also important that you take those laps away. So if you look under the drapes and there's a lap that's soaked in ChloraPrep, right, that's a definite no-no because this is, the 3 minutes they require is for something to just kind of be applied and not a pool of, alcohol that's going to take longer to evaporate, right? So that's the biggest risk is that, and then these things go on the drapes, and that becomes a problem. The ignition source usually is pretty, again, this is, the cautery, the stuff that they're using. Other things that you think about is the light sources. So a lot of times I don't know if you remember from your surgical rotations, but, they'll kind of be put to the side and someone touches it and, oh, this is still really hot, So the light sources, glowing embers from charred tissues. I don't know what type of surgery that is, but it can be, so obviously anything that can cause a spark, right? So just kind of think of those things. And the oxidizers, oxygen is obviously the clear one, but actually nitrous oxide can also be an oxidizer. So we don't use it very often, but also keep that in mind. And then the other thing about the oxidizer is that not only is it the oxygen coming out that's important, but where it's going, right? So, cataracts, things where you drape the whole patient, and now if you have an oxygen source that's, they're getting nasal cannula, it's pooling down around their, face, that could be a source, right? So things to consider, decrease FiO2, especially when they're around the airways. So the big thing is, if you're doing a trach, if you're doing any sort of ENT procedure around the airways, that's when you really want to be careful about dropping that FiO2, dropping it down to 30% if possible, and if not, just really talking to the surgeon about what we're doing and really trying to minimize that time that you have where there's a potential for cautery and high oxygen source. And then the configuration. You can put suction down, and a lot of people do, not only just for the oxygen, but for CO2 clearance as well. So I know you guys probably don't do that many cataracts in general, and it's totally fine. But the one thing to remember is that the drapes, come down, and so stick an oxygen or a suction down there. It'll kind of help with the airflow.
So they're just like open to air, just pulling.
Yeah, just kind of like just leaving it down by the chest sometimes, or just making sure there's enough kind of ventilation if there isn't the case. Sometimes you'll see. Not just necessarily in those cases, but in other MAC cases, the inspiratory CO2, like the CO2 waveform, will start showing rebreathing, and then you know that there's got to be rebreathing of air, and it's probably likely you're increasing the oxygen around that, especially if there's an O2 cannula right there, right? So the ASA has an operating room fire algorithm. So take a look at it. It's seems pretty straightforward. Like, first thing you want to know is there a high risk of fire, and this is where the fire risk assessment comes in. And then thinking about, the most important thing is obviously prevention, right? Trying to prevent all those three things from being coalescing at the same time so that doesn't happen. And then coming up with a plan, especially if there's a high risk, to come up with a plan to kind of minimize the risk, okay? So the interesting thing is after that. So, okay, we'll talk about the FRA first. So fire risk assessment, so you can talk about it for left chole, cataracts, thoracotomies. So what is it? Have you guys heard of it? They say it's 1, 2, or 3, right? Yeah. So if it's 1 or 2, it's usually low, and 3 is high. And when it's high, we think of ways to mitigate it, right? So this is the fire risk assessment. So 3 things. Is it above the xiphoid? Is there an open oxygen source? So that means cases that are not an LMA or a tube, right? So if it's an open source, it's actually a higher risk of fire because the oxygen is going straight into the chest with someone with a tube. And is there an ignition source, right? So for lap chole, what would it be? So it'll be a 1, right? Right, it's above the xiphoid or below the xiphoid, right? Patient tube, but they're using Bovie, so it's 1. All right, thoracotomy, 2, and cataract,
3.
So cataract will be 2, right? Because usually it won't be Bovie. But let's say it's a laser for like a papilloma in the cords, right? That's obviously going to be a 3 because above the xiphoid, open source, and depending on what type of oxygen delivery you do, it could be like jet ventilation or something. That could be a 3. Okay. Technically, it'll be a 2 if you use the tube, but still, higher on the risk. So it becomes 3. You think about high risk protocol. Think about drapes to minimize settings for the Bovie that you can kind of minimize if you can. Encourage the use of a lot of these things are for the surgeon, but obviously you can kind of give suggestions if you feel like they're doing something that's not right. And some people actually, if it's a high risk, they'll keep like a little thing of saline. I do it once in a while, just so I have a bucket to throw on the fire if you need to, right? So a syringe full of saline or a little water, sterile water to be around. So the first thing, right? So what do? You see a fire, right? Announce that there's a fire, right? So not many people will see it because this is what happens. A lot of times it'll be like on the side, the drapes will catch on fire or something, and because somebody left a hot material or something like that. There was another time where I was involved, but it was at the place I was at. A lot of times we do CO2 to flood the field on bypass, and the perfusionists changed that to oxygen. So they were Bovieing, and one of the laps caught on fire. So no harm to the patient, but it was like it's kind of scary. So announce that there's a fire, turn off the oxygen source. Okay, so stop if it's around the airway, especially. All right, turn off the oxygen source. If it's the airway, that's the biggest thing. So if it's not the airway, right? Announce the fire, put out the fire, right? So, water or remove all the stuff. And then right after that, you got to remove everything right? That could be potentially, because if the clothes is still, hot, but then it's not on fire, that could cause a burn still, right? So remove everything that could potentially be flammable and then re-prep and drape and finish what you need to finish, right? If it's in the airway, it's where you turn off the oxygen source, okay? And then what do you do with the ET tube?
Throw it away.
Right? You should always take it out, okay? Because especially if when the ET tube is involved, always take it out because that plastic will cause more injury, okay? I mean, if this is like an impossible intubation or something ridiculous, then, you can think about not doing that, but really the teaching is if whatever is burning, which could potentially include the ET tube in the airway, you should remove it. Put a new tube in. You can flood the field. You can put saline down the trachea. That's all fine. Then put a new tube in, suck everything out, and then deal with whatever is above. So it's one of the few times where if there's an emergency, take the ET tube out. So it should be something that seems counterintuitive, but you really want to remove the thing that's on fire. So those things.
When
Yeah.
you remove, it says stop the flow of all airway gases, is just regular air. Is that what you're putting on? What do you something?
So you want to stop ventilating, right? If it's an airway thing, you want to stop ventilating. You want to put the fire out.
A non-airway fire, if you're in the right side.
Stop the flow of all airway gases. I think that's just really to, make sure that everything is, you're not increasing this, because there's three things, right? The oxygen source. So really minimizing the oxygen source, making sure the fire out, and then restarting it. I think if you know for sure.
But if they're intubated, you just leave everything.
I think if you're intubated and you're pretty sure that it's far away, I would keep things going.
Okay.
If it's a mask, maybe turn it off and move it out of the way. So really removing those three things: the oxygen source, the spark, and the fuel. Removing those three things as quickly as possible, making sure the fire is extinguished, and then reestablishing everything is what they're saying.
Okay.
Makes sense, right? I've seen patients that have had these issues afterwards. They get tracheal stenosis. It's really, really bad. So it's something, especially with any ENT procedure. You can't assume, especially at a place like this, there are tons of different people working. You don't work with the same people all the time, and that's not really an excuse either. Like even if you do, you should always make sure that they're in a 502 and they know you're a 502, and you know what their plan for Bovie are. Really, that's kind of the biggest thing, right? Fire extinguishers. This is like your credentialing. Like, okay, you got ABC different types. Want to use the one with all types. That's best for everything, right? And then reestablish ventilation, and then maintain it. And then most of the time, if it's an airway thing, you definitely need to do a bronch and make sure it's clean. Okay. Electrical safety. So, don't do that. Water and electricity doesn't work. So what is a ground? I'm not an electrical engineer, but for most of us, a ground is the third prong, right, on the plug. For a technical term, it's basically an infinite source of electrons that you can either give electrons or take electrons from. Okay, and that's usually some sort of connection to the earth, right? Typically the third, so usually the way things work in an outlet, you have a black wire, that's the hot wire, the white wire, which is the neutral, but there's charge going through the neutral, so you don't want to touch either one of those, right? And then there's a ground, which is a wire that goes to somewhere that attaches to the earth, right? And usually when you turn something on, when you plug something in, it's going from black to white, and white to black, as an alternating current, and the ground is there in case there's a fault, right? And how does the grounding work? So basically you have a plug with some sort of electrical equipment, and then you have a metal case, and then the electricity is insulated within this case, right? But if there is a fault, and that somehow the electricity gets from the case, from the wire to the outside of the case, then the ground wire, which is down here, creates a path where the electricity goes to the external metal case and then goes back into the ground instead of going to you if you touch it, right? Because it's the lowest path of resistance. Line isolation is something that is part of they'll ask in the ASA what is this line isolation thing? And it's really annoying. So do you know what the situation with line isolation is in the UCHORs? It's not isolated, right? There's no isolation. It's an older thing. So each, the operating room itself, the outlets are not isolated because these isolation transformers are in all of the medical equipment nowadays. So that this kind of pathway is no longer really, the usual standard. The old VA hospital had a line isolation monitor. To know that, so wherever you end up going, right, you're going to be in an operating room. You don't know if there's going to be isolation. There's going to be a little thing in the room that has a little voltage meter, and if they have that, that means the outlets all have a line isolation monitor, or they're isolated. What's that?
They have it at the new one.
The new VA as well? Okay, well maybe they do that. So you'll see that, right? Do they go off and people just ignore it, or that's probably what happens. So the thing behind the line isolation is that you have an isolation transformer so that you keep the wall outlet, so the power supply going to the operating room is isolated from the ground. And the way that you think about it is that, let's say, this is the interesting picture. So you have an isolated transformer, right? So if there is an open pathway to the electricity and you touch it, because the isolation transformer keeps it away, keeps this loop separate, there's no way for these electricities to go into the ground and then back into the loop again, right? So that prevents it from happening. So that's the safety value of the line isolation transformer. But then if there's a fault in that there's another place, so you're touching it, and also there's another place where the metal case is touching the electricity, now you have a loop form, right? And that's bad. And then, in order to prevent that from happening, you have a monitor. So basically, a monitor replaces you as the person. And then whenever this fault happens and this loop forms, this monitor will go off, basically. And usually, I think, so the biggest thing is, the question will be, what happens when the isolation monitor alarm goes off? And it's usually, there's a fault in the last piece of equipment that was plugged into that circuit. And so that needs to be removed and checked, and you shouldn't use it. And that's basically the main question that you'll get asked. There are microshocks, macroshocks. Microshocks are 50 microamps, so they're tiny. And there's some level, 10 microamps is a leakage acceptable according to, the guidelines. And that's for issues, that's for shocks that if they occur inside the body, that can be lethal. And usually most of the time, those are, if we have like central venous catheters that have EKG monitors, which these things we almost never use nowadays, those can potentially be at risk. And, most of the safety equipment, we don't prevent microshocks. Macroshocks, which is over 100 milliamps, is what we prevent. There are different levels of perception. So, this is where you hold at the amusement park, you hold that little guy and it shocks you until you have to let go. So usually the let go value is from 10 to 20 milliamps. And then it goes as high as, it goes up and you can start getting VFib around 100 milliamps and above. So that is not good. So big take home, don't touch exposed wires, keep it as dry as possible. The line isolation monitor is that there is a ground fault in the equipment, and usually when it goes off, it's the last equipment. And do not ignore alarms. Pretty important. Why do we check bovie pad sites?
To ensure that there was enough surface area, that there's not a focal area of contact, which could have created
which could lead to a burn, right? So the way bovie works, and these are things, I think, I try to make this into something that can be kind of useful, even if it's not, if it seems kind of boring. So bovie pads, so the way that bovie works is that you create a current, right, from the bovie site through the patient to the pad, okay? And that's why when you think about putting, if they have pacemakers and things like that, having it as far away from the bovie pad as possible, okay? And also that's why the nurses ask about hips and knees, they try to keep it away from those things as far as possible, in case that leads to some aberrant conduction, because they really should conduct from the area of maximum heat to the lowest heat, and that it should be enough of an area. The bovie machines that's why they have the alarm when they don't have enough contact, because then that'll cause thermal injuries if there is enough air contact. So that can happen if the gel is dry, right? It can happen if they lose contact or it's old and stuff like that, something like this, right? These are burns, it's not good. Other things, we use monopolar, which is what we just talked about with the bovie, high current that goes through, and then it spreads out so that it doesn't cause issues. That's why we talk about metal and jewelry, so we really should take those out if we can, because if somehow there's the ring or whatever is in a puddle, right, and somehow it goes to some other place, then it can cause, or it's connected back to the circuit, then it can cause a burn. Bipolar is where the two ends, the electricity just goes from the two ends, usually with neurosurgery. Occasionally, other things that are sensitive, like OV for fallopian tubes, AICD, things like that. Argon beam is basically it's not a laser, it's actually monopolar, but the tip of the argon beam doesn't have to touch the tissue, so it kind of jumps, right? And they use it, especially in liver cases, because what happens with monopolar is that all this char builds up, and then you scratch it, right? So the argon beam, it prevents that because it doesn't actually touch it and just kind of jumps across. There you go. Same concerns as the monopolar. Okay. Implantable devices. I have a whole separate lecture on these. So basically, try to avoid as much as possible, trying to stay away from the implantable devices. And then the interrogation part is a whole nother lecture. The big thing not to do is to put a magnet on and not be sure what it does, right? It's a potentially life-threatening maneuver, right? And so don't just put a magnet on. The only time where it's excused really is when there's a trauma, you have no idea what's going on, and you think, and you're pretty sure they have an ICD. And that, potentially putting a magnet on the IC will deactivate it, right? So that's the biggest thing. The two things that you really want to be careful of during this is that if they have an ICD, you don't want the cautery to be sensed as electrical activity, ventricular activity, and cause it to fire, right? So you really want to turn it off. I am pretty aggressive about having them turn it off. If they're doing any sort of cautery close to it, even if they tell you not to, you really can argue with them about it and get them to turn it off. Especially, my quick excuse is whenever they say, oh, just put a magnet on it, I say, oh, they're going to have drapes on and I can't see the magnet. And that's usually good enough to say, oh, they're going to be lateral or they're going to be bumped or, anytime you can't see the magnet the whole time, which is in a lot of surgeries, right? I feel like that's enough of a safety concern that I won't do it.
Do you always put pads on in those situations, or do you just gauge them?
It's up to you. Most of the time, I think it makes sense. It doesn't. So I think certainly, depending on the type of cases you do and things like that, I think you can make an argument for it. I've had people say, this person gets a low EF is an indication, right? EF under 35% with the left bundle branch is an indication for, just under 35% is an indication for potential ICD for risk of arrhythmias. And in that situation, the chances of it going off are very low, right? Especially if they haven't had primary VT before, right? If it's just a low EF and they have a dilated heart and they're at risk. A lot of times, we'll do a heart transplant and we're on the third floor and they're like, oh, we can't turn it off when we go downstairs. And you're like, well, he hasn't been shocked in 5 years. When is he going to get shocked from for the 10-minute walk down? So sometimes I won't do that, based on the indication of what we're doing. But for other things, if they had, other arrhythmias, like if they have documented VT, things like that, then I'll definitely put pads on, things like that. So it kind of depends, but most of the time, the answer is easy to be yes. Yeah. I wouldn't say I do it 100% of the time. The other thing is if it's a pacemaker and they're completely dependent on it, right? And the bovie is interpreted as electrical activity and they don't pace. Right, so those are the two situations that you want to make sure. You want to make sure that answer is no for those two situations, and you can do whatever you want to do, to make that the case. So those are the two big important things to know about. So usually, if it's a pacemaker, and they're not dependent on it, what do? Just leave it, right? If they're not dependent on it, they're paced like 5% of the time. Just leave it, watch. If it starts inhibiting and, their pulse ox goes away, right? If they don't have an arterial line, they have a pulse ox, and then you just tell them to stop, right? And if it keeps doing it again, then you put something, you either reprogram it or put a magnet on it. But most of the time, if they're not 100% dependent on it, you can just leave it where it is, okay? And then most of the time for ICDs, turn it off. That's like the easy answer for these two things. And the third thing you don't want to do is leave it in an asynchronous mode when the patient has a native rhythm that's competing. Because then you're going to have two pacemakers going at the same time. And if the pacemaker fires while it's repolarizing, that can degrade into a ventricular arrhythmia. All right. So, when you go on to PACU, they tell you like what the respiratory rate is, and you have no idea what's going on because you're like, how does this happen? And they use impedance plethysmography, plethysmography, yeah. And basically, it looks at the electrical amplitude of the EKG signals, and as the chest wall rises and falls, that electrical amplitude changes. Okay, and that can have an effect on some pacemakers if it has a rate responsive function. So I've never seen that. Sometimes it can happen. So that's also something to keep in mind. But that's how those things work. Just in case you were wondering why these respiratory rates are there. Last thing, lasers, light amplification by stimulated emission of radiation. So basically, radiation goes through some sort of element that creates light. They also allow heat to be applied to a very small area that helps in medical settings. There's risk to providers and patients. So the big things to remember is class 3B and class 4 lasers are what we want to wear eye protection against. So they're classed by the safety of, basically like looking at the beam, right? So if it's class 3B is unsafe for intrabeam viewing. So if you point it at your face, that's not a good idea. But it won't cause by energy bouncing off the laser. And then class 4 is causing causing skin and eye injury from direct and reflected energy. And class 3B and 4, these lasers can cause damage before your aversive reflex with the eye, right? So these will cause damage in the time it takes for you to notice that there's a laser in your eye and turn your head. So those are bad, right? And there's no you can't just I'll just turn my head real quick, that doesn't work, right? Apparently you can buy these lasers on Amazon too, which is, someone was telling me about these lasers. They're like, yeah, you can buy class 3 lasers on Amazon. It's probably not safe. Yeah. And they're all defined by, basically, light goes through some sort of medium, some sort of element, and that's how they're defined. So most common are CO2 and YAG lasers, and that's why you need to wear the glasses. A lot of times when they're testing the laser, it will say, okay, everyone turn around. It's probably unsafe. You just have to make sure to close your eyes or put glasses on. And also depending on the type, and it's really, no one can remember this, but not all lasers, some are okay with if you have glasses on, but even then, you don't have protection on the side, and in some classes you definitely want laser goggles. So you just go by whatever the manufacturer recommendation is, and different for different.
So are
elements.
CO2 and YAG, are those class 3B or class 4?
I'm not sure which one they are.
But they are
yeah. But those are the most common ones that we use in ENT and stuff like that. They can cause perforation, gas embolism, other things like that, airway fires, exposure to the eye, things like that. Good. Burns, laser plumes. So you can get if you're burning HPV and Hep C and HIV, those can all go into the respiratory system. It's not good. Certain lasers, so YAG lasers during hysteroscopies can cause venous air embolisms. So that's kind of a very rare, thing. But if you get hemodynamic compromise, something to think of, and then eye injuries. So the CO2 lasers are the ones that are protected by any sort of plastic. But I'm not going to remember that enough to know which one's okay or not. Okay, have you guys used a laser tube? before. So these are the ones we have. They're by Malincra. They're different types. And so you have two balloons, one proximal and distal. And this is for airway surgery. Basically, thought is that if one pops, what you do is you put some sort of methylene blue or something in the one that's closest to the beam. Usually the most proximal part of the tube, and so if that pops, then you get like this blue explosion. It's like a bank, like tag, and then you know that you've already kind of burned through the your cuff. So, and it's also armored so that it doesn't cause injury. That'll poke holes in the laser. So in the tube, that's about it. Any other questions or anything else? It's not a super interesting topic, but it needs to be done. So, these are all like pretty, seems like pretty straightforward until like it happens, right? And then you're like, oh, this is terrible. So, just don't do anything ridiculous. All right. Yep.
Thanks.